I know we've gone around the room, but let's do it again. What do you think? You want to start us off, Jane?
Hi, everyone. Judy Palin. I'm with the Minnesota Association of Community Mental Health Programs.
Hey, Kevin Magnuson, Washington County attorney, and I'm representing the County Attorneys Association.
Gary Gallagher, Department of Human Services, Direct Care and Treatment, admin support for the task force.
Hi, Angela Youngerberg. I'm from Blue Earth County, representing MAXA.
I'm Miranda Rich. I'm representing HCMC, the Diversity, Equity, and Inclusion Consultants here to represent people in the correctional system.
Hi, everybody. I'm Terrell Clark. I'm the Stearns County Commissioner, and I'm representing the Association of Minnesota Counties.
Do we have Holden, Executive Director of County, Minnesota?
Hi, I'm Nick Rasmussen. I'm a governor's appointed member with lived experience in mental health.
Felicia Rooney, I'm with North Memorial, representing MHA. Good afternoon, everyone. I am Lisa Harrison-Hadler. I'm the Deputy Ombudsman with the Office of Ombudsman for Mental Health and Developmental Disabilities.
Hey, I'm Heidi Hano, and I'm appointed by the General Member.
Kylie Stevens, Executive Medical Director at Direct Care and Treatment, and I am DCT's representative.
Brian Love, Sheriff with Cass County, and I represent the Minnesota Sheriff's Association.
Thank you. And we'll have more people join us as we come in. As you see, there's some refreshments on the side, and the bathrooms are right back there. And we appreciate everybody putting their time out, because this really is critically important problem, which I believe we're in a position to try to put forward some thoughtful ideas on how to improve and resolve this challenge of priority admissions. We're going to now review the minutes. Has everybody had a chance to take a look at the minutes? After everybody takes a look at them, I'll entertain a motion to approve the minutes from last time. Second.
I'll second.
All in favor?
Aye.
All opposed? Good. We got something done today. Great. Yeah.
Something done last time.
Yes, we did, but now we're on a roll, That's right. And so good. So now we have some things that we did go over last time and we want to follow up on. The first point is SharePoint updates. I'm not sure, there's not a name next to that, so.
You're looking at me, so I'm happy to update. I just wanted to alert folks that there is, I don't think it's technically a SharePoint, but it's a shared website that has all of the documents, and we've been putting documents as they come in over the course of the last several weeks as well. So if you need anything, that's the best place to go, and it's accessible.
And I want to thank you because I found it to be helpful and useful. Yeah. Any discussion on the SharePoint?
And so we all have the login information for that sometimes.
There's no login.
Okay.
You just need the link, and Carrie included it in the minutes last time, and I'm sure we'll again this time.
Great, thank you.
And data for review. Stevens?
Yes, I will take that. If you all want to open this. Start there. So if you recall, during our first meeting, we presented several pieces of data, all of which were required under the statutes for the task force to consider. There was one remaining piece of information that we hadn't been able to figure out how to bring to you all yet. So we'll be covering that here, and that's what's included in here as well. And then there had also been a request to visually see where the beds operated by Direct Care and Treatment are located. So we'll go through that as well. But we can start with this sheet. So the first graph that you'll see reflects the average days from someone who is referred for admission to actual admission to Anoka Metro Regional Treatment Center, or AMRTC. We chose AMRTC because that is where primarily we feel the impact of priority admission statutes. I've kind of started thinking about it as like a ground zero for the statutes. That's where we see the most marked difference. So you'll see here that various graphs of course, or various lines, of course. And it shows from 2013, where the statute started, up until June 30th of this year, where the length of time from referral to admission took place. So the hospital referred here as the dark blue graph are community-based hospitals. Jail refers to people who were referred from jail and admitted, but they didn't qualify for the priority admission statutes. They were just referred from the jail. The gray bar is the jail admissions who do qualify for high priority admission or priority admissions. The date there is a little bit different. We had to use the court order date to admission date to make it as clean as possible. I think the trend there that you'll see is, up until 2020, and then steadily after that, the time it's taken to admit people, even under the priority admission statute, has gone up quite a bit. Moving on to the yellow line, these are admissions to AMRCC from other sources. So this could be from home, someone who's homeless, detox center, etc. And so you can see the length of time for that is quite large as well. And then occasionally we do have admissions from prisons, and these are individuals who are civilly committed, and their discharge or upon release, they've been referred for admission on the basis of their civil commitments. If we look to the next page, this looks at the actual total admissions to AMRTC by year for each of these groups. So we wanted to be clear that the numbers of admissions received from these various sources differs dramatically. So for example, the hospital admissions, starting in 2013, we had over 100 of those per year. As of 2013, there have been 1 admissions from community-based hospitals to AMRTC. From jails, it's been pretty steady, but down to 5 this last year. High priority admissions, that of course has gone up, which we've talked a lot about. Other referrals, so again, from some sort of community-based program, there were just 3 in 2022 and none so far in 2023. The prison population or the prison admissions has remained not terribly different from each other across the years. Any questions on these first 2 graphs? Because they are paired, they go together. And there's quite a bit of context here. I tried to anticipate some of those questions. If after the fact you have any, happy to answer those as well. If we flip the page, we are looking at this one right here. We switched to average referral days for non-admissions to AMRTC. We felt it was important to note not only those who have been admitted to AMRTC during this time frame, but those who were ultimately not able to be admitted and therefore had some other disposition. So the categories are the same, so no different explanation is needed there. You can see there's some wide variability in terms of how often people were not able to be admitted. A trend that we're starting to see is actually people who do qualify for priority admission ultimately not coming to the program to AMRTC, and that could be for various reasons. Either there's a different disposition or they were able to be diverted into another sort of placement. But wanted to reflect that just because someone's referred for admission, oftentimes that does not mean that they're able to get in. And then the final page on this sheet shows, again, the total number of non-admissions to AMRTC by year. So you can see that there's been historically quite a large number of hospital referrals to AMRTC, and those have really tapered off. And that's because hospitals know that there's no way they're going to get an admission to AMRTC, so they don't bother. Any questions about these?
Before we move to the next thing, we have some folks who just joined us, and we also want to have intros from everybody who's here today, since you took your time to be here. So why don't we start here, Doc?
Hi, I'm Dr. Deanne Hart. I'm a psychiatrist and addiction medicine specialist, just getting off an overnight shift at Hennepin.
Hi, Dr. Kathleen Heaney, addiction psychiatrist, Hennepin County Medical Center. Dr. Cologne asked me to attend today to represent NPS in his place. He's out of town.
Good to see you both. Laura?
I am Lauren Sales. I'm the legislative director for the Attorney General's Office.
Hi, Karen Roth, Senior Advisor for Policy and Special Projects, Attorney General's Office.
Bill Klitzky, Deputy General Counsel.
Greg Ramos, Legislative Director for Drug Care Treatment.
First Brown, Communications and Media Relations, Director of Treatment.
Marshall Smith, Health System CEO for Director of Treatment.
Folks in the back?
Griffiths, Managing Director at Division of Director.
Jessica Law, Advocacy Engagement Manager in Healthcare.
Going all right with Paul House.
As there was, Urban Affairs for Memorial Health.
Matt Freeman, Executive Director for the Minnesota Association of County Social Service Administrators, or Enacted, and Policy Analyst for the Association of Minnesota County Administrators.
Okay, good. So, Dr. Stevens, thanks for that data review. Anybody have any questions? Comment, follow up? Okay,
We
fine.
do have one additional
Right.
sheet to go through. You have two very similar looking maps. The one that I'll reference doesn't have any writing on it. That isn't just the pictorial here. And Angie will talk about the other one. So this, I mean, very self-explanatory, explains where the beds are and which level of care. So CARE, Community Addiction Recovery Enterprise, is our inpatient, well, our locked substance use facilities. Our
Sorry,
six-
which map are you looking at?
the one without writing on it.
Got it. Yeah.
Thank you. Community behavioral health hospitals, we have 6 of those dotted throughout the state in red. Anoka Metro Regional, which is of course in Anoka. Our forensic mental health program, located in St. Peter and where Dr. Griffiths works, who just introduced himself. And our MSHS programs, which are the PERTS facilities, also throughout central Minnesota.
Thank you. Okay, good. So from last week, we also want to hear on prior admissions processes pre-2013. And for that, we have Dr. Stevens and Rutherford.
Would you like to start, Angie?
Sure.
Let me break for my voice.
So, one of the things that we thought was important is to not only talk about where we're going, but to also understand the context of where we've been. And I really appreciated this document that was put out for the task force. And so I stole it and then wrote notes on the side. So that is a county perspective about what admissions used to be like at some of these facilities and what it is like now from a county perspective. This is not meant to be a technical document. This is meant to be a contextual document. So this is how county case management typically experiences and how they talk about who's eligible for admissions at certain types of facilities. And so just want to make that very clear that this is not the priority admissions or the admissions criteria. This is how it looks from that community perspective. And so on the left-hand side, I have prior to 2013. And again, really, there has been a lot of change that's happened since 2013. And even before that, our system continues to evolve. So it's just important to know kind of where we've been and where we are now. And so CARE, which is the Community Addiction Recovery Services, it was really available to anyone who needed chemical dependency treatment. That's generally how it was talked about. Now, it's really that high level and locked type facility for individuals with really high complexity chemical health needs. The CBHHs, there were 10 initially, and so we used to be able to access multiple hospitals in that CBHH system. There are now 6 of them. In the beginning, we used to talk about voluntary admissions, someone who really wants to seek hospital level of care for themselves in a very proactive manner. We used to talk about the CBHH being an option for them, and it did happen prior to 2013. But given a number of systemic changes, what it's like now is in CBHHs, we're really only looking at those individuals who are civilly committed as MI or MICD. The Anoka Metro Regional Treatment Center, I would say, has had the most significant change since 2013. There were a lot more, there were many more beds available at the time, and I don't have the exact number, but it's, much, much higher, around 200, maybe just short of 200, something like that, prior to 2013. And so therefore, there were more buildings that were utilized at the time, and they provided competency restoration. Typically, this was still civilly committed individuals that were in need of longer-term psychiatric services. Now, it's really that priority admission criteria only is how the county views it and sees it, although the data shows that there are a couple of individuals here and there that are able to come from the hospital or that don't need that that designation. So, but it's a very small number. Forensics, which was Minnesota Security Hospital. From a county perspective, we never had troubles getting anyone into that level of care. We could almost facilitate same-day admissions when that was needed years ago. And so initial evaluations occurred there. Now they occur while the individual is typically in jail. And right now, for forensic mental health programs, the individual must be civilly committed as mentally ill and dangerous. They must have that full commitment done. So it's not typically that initial commitment. And what I'm hearing from peers, Blue Earth County doesn't have the exact experience right now, but peers are stating between 8 and 12 months wait to get someone from AMRTC to forensics. Now, there are exceptions and things take different amounts of time, but that's significant in terms of the change. And then the Minnesota Specialty Health System, this is an area that we didn't have the state providing that level of service. And so now we do. So that's a significant improvement from a county perspective, because there are IRTS facilities, intensive residential treatment services, that are either locked or have flex locks. So they're able to work with individuals that have an elopement risk. And so that was a significant change for us from a community perspective. That was an ad that we found quite beneficial, but it's been heard over the years.
Yes. Yeah, I can offer a little bit of additional perspective from the state's point of view. I spoke with Dr. Steve Pratt, who was my predecessor, and was with us before, well, he's still with us, but with the state before the priority admission statute took place. He said by about the early 2000s, the wait list at AMRTC grew to about 100. So similar to what it is today, actually. But at that time, they put in a lot of effort into diversionary processes. They started doing remote provisional discharges from other places. And that worked really well. Also worked closely with the counties to facilitate discharges, because admissions at that point in time to AMRTC were much longer and for a more stable patient population than we see now. People in need of that long-term subacute care is really what it was at that point in time. He said between those efforts as well as the CBHH's opening, that eliminated the wait list. But really focused on those three efforts: the diversion, working with counties to facilitate discharges, and then the CBHH level of, well, it's the same level of care, but the facilities opening. In terms of how they prioritized, he said that Typically, first you would look at the date of commitment. So people who were waiting longer or committed earlier got first priority. But that was flexible and they looked at acuity. So if someone was really very ill or in an unsafe situation, they prioritized individuals from those those areas. And also capacity of their current placement. So if they happen to be in an emergency room and the hospital didn't have behavioral health unit, or they had a small behavioral health unit and the person was too ill or have too many difficult behaviors for that unit, that they would also prioritize those. So we do see, and we still use the same sort of prioritization for our non-priority admission areas. And to be clear, we do admit to all of our levels of care where we can safely admit and treat people with under the priority admission. Most cannot, like the CVHHs, our CARE and MSHS programs. So we do use the same prioritization for those folks who needs it the most, who's been waiting the longest.
Any discussion on this issue? Does appreciate the historical perspective.
So what happened in 2013? I mean, why is that a date, a benchmark date?
That's when the priority admission statute took place.
So
So I have a clarifying question. I know the CVHHs use Medicaid. Do the Minnesota Specialty Health Systems use Medicaid as well?
They do.
So we can use Medicaid in doctors' facilities.
They're not locked. They're flex
They're
locked.
flex locked.
So yes, these are not secure groups.
And 690 beds is today.
Right.
And so prior to 2013 total?
Commissioner, I don't have those numbers offhand. I wonder if someone here knows that offhand.
And I've heard comments about the Miller building. There used to be more capacity.
The NRTC capacity, I think it was 170.
Yeah, it was the upper hundreds, almost 200. I think that the CVHHs, I mean, they did have 160 beds when they initially opened, and so now that has changed too. And I think the Minnesota Specialty Health System, that was a conversion of some of the CVHHs, so not the hospital. So if we're counting the hospital beds, that was a loss, but it was also a gain from a community perspective to see those IRFs facilities. I don't have that number. I would guess it was significantly higher, but I don't.
And the overall capacity decreased because of staffing, funding, the buildings wore out, but
A lot of it was funding, but also patients were expecting to use private rooms. So we stopped double execution.
And I might clarify too, that the patient population at AMRTC is vastly different than it was a decade ago. It tended to be people who had already been at a hospital and just maybe weren't stabilizing as quickly, or had, neurodevelopmental conditions that required some unique supports. They had a geriatric unit for a while. Dr. Pratt told me that assaults were rare between peers and also on staff. So they were able to fit more people safely in the building, and that's just not the case now.
and I'm sure we could go on for weeks about acuity levels and why they're so high today versus 2013, but 2 or 3 thoughts from anyone in the community or from you?
I just had a question. I was talking to a former employee, and he mentioned that the staffing changed when they lost a contract with another sheriff, like they used to have sheriffs in the house. And I'm just wondering if anybody feels like the security level, like, is like literal security in the building, and with staff, did that change how many, like the staff to patient ratios or the sense of safety, and that led to staff changes?
We for quite a while, there was a contract with the my understanding, so correct me if I am wrong, Marshall or anyone else, but it was a contract with the Anoka Police Department to provide like resource officers. We made a switch based on various things to being a staff-led safety response and developed internal teams to do that. So I wouldn't say that that resulted in a less safe environment. There's no uniformed officers, which for a lot of folks, that's probably a better thing. And the philosophy of care and support differed. And I believe it to be better now.
So if I could back to the question about general community acuity and Weiselheim. In the past 3 years, methamphetamine and fentanyl use has skyrocketed. Our patients at HCMC are greatly affected by these drugs, and our level of violence has skyrocketed. And I beg to differ, if I may, with you, because I work with a psychiatrist at Hennepin who left Anoka about a year ago, and she reports very dangerous, scary conditions when she left Anoka. So on our own units, the violence has skyrocketed. We have many staff leaving. We have many assaults. And one nurse practitioner told me last week, there's going to be nobody left to take care of these people. We have a guy on our unit, inpatient unit at Hennepin, who's been there over a year and has assaulted 100 people. So I'm not saying that methamphetamine and fentanyl is the only reason, but that is a strong reason why our patients and the way they are is different than in 2013. It's a strong influencer.
Well, we had illegal drugs in 2013. Is there something different about this?
Very much so.
Yeah.
You would get a cocaine washout, they do cocaine, they wash out, they go. Methamphetamine, psychosis, more violent, more paranoid, and longer lasting.
I would just say, like, if you have like a dopamine release, which can naturally makes people feel good, you have like a outstanding meal, goes up like 100. You have sex, 200. Methamphetamines, 4 to like 10,000. So, I mean, that's a big difference in like chemistry. So, I mean, I know people talk about this is not my grandfather's pot. Like they talk about all the things that are in pot. Methamphetamines, like we have rightly so had a lot of attention to opioids. People who recover from opioids, you give them the right medication, the right treatment, they can get back to close to their normal function, if not. Methamphetamine, people, I mean, very different. Like a lot of them are persistently psychotic and agitated. Like there's not as much attention to the methamphetamine problem, but those patients just do not recover in the same way as other people who recover from substance use. And I haven't done the research myself to know like what is the difference, but very different brains. Very different brains. So I agree that does factor into it. I don't know how much of a problem that is if you look at all the factors, but I do believe that there should be some attention to that.
Are you seeing more hard drug use at a younger age as well? Like, which of course, then even if they quit, the development is totally different.
Are you
They're
all saying?
vulnerable brains.
Are you all saying that the law changed in 2013, right about the same time as that a new chemical substance sort of hit the street? And those things happened at the same time, and that's why they're driving the higher level of violence. And are you saying that?
I didn't what law changed?
The 2013.
Oh, with that 48-hour rule, and you're wondering if methamphetamine came on around the same time?
Yeah, and then, yeah.
I'm not sure,
Okay.
but I would say it's going like this. Methamphetamine has been going like that. I don't know if it exactly started in 2013, but it's been going like that. So that's an interesting question. Are those coincident? Did they happen simultaneously?
Yeah, because in my mind, I'm thinking like, well, did the law not work? Did it work? But there was an introduction of this drug, so it didn't work. You know, so, I mean, if you're trying to fix a machine, you gotta know which part of it is
Correct.
not working
Yeah.
right. So,
I mean, in our business, we have to think multifactorial, so it's multiple things. So closing of beds, not having enough locked facility, right? Large numbers of people who come to this state, because we know, working in an emergency room, people come from other states seeking housing and services in this state. So increasing numbers of people who need services. And if you don't have jobs and you don't have a place to live, and you may have had a criminal or drug history, that comes here. You have a law that gets passed. So I think it's a multitude of things. Then you have the pandemic, you have George Floyd. So you have many, many things that I say would contribute.
You know, I mean, that started out right, in the 80s, biker gang kind of thing. It's been a part of the drug scene for a long time. But I think to the point, the cocaine, for example, crack, and that was an epidemic. And as that waned, as penalties grew, meth became more of a drug of choice. And the effects, at least in, they should share probably be terrible, but you know, the stuff that we see in law enforcement, so much of it bears out what you're saying. So much of the crime and then the meltdown, all this component.
We used to see
meth.
a lot of home cooks. And we'd have them that couldn't pass high school chemistry, mixing all these chemicals. They didn't have a very good product. 2006 happens and Sudafed becomes only available for so many doses. And you see Mexico then importing, and they get it down and they get a more pure drug. And when I first started, we had meth labs all the time. We're breaking up. I haven't done one in years.
right.
So I think some of that, where you get a really good pure product that you didn't have before.
I found the data you're looking for Anoka. It was from a legislative report. So the average daily census, different than the number of licensed beds, because that was in 2008, it was 193 licensed beds, but the average daily census was 170. But then in 2009, that dropped to 131. In 2010, it dropped to 113. 2011 was 110, 2012 was 108, and 2013 was 106. The average length of stay in 2008 was 75 days versus 105 in 2015. So that also goes to the more complex issues that people are presenting. So some loss in beds, but not hundreds.
Right. I do think that the change from the forensic program, not change from the forensic program, that's not what I'm trying to say. The inability to quickly access forensic level services and admit someone there. And so what we used to be able to do is get the individual who has the specific need into the right and most appropriate treatment place for them. Now we are having to use other methods, whether it be staying in jails, using AMRTC, using these other options, which is not the same as using a bed at forensics. We're not surrounding the individual with the type of treatment that they need, and therefore it creates opportunities for the individual to, it's kind of the recriminalization. So they're not treated as they need to be. So therefore they're acting out in emergency departments. They're assaulting staff, where if we could have gotten them into the appropriate treatment, that may not have happened. So it doesn't speak to the sheer number of individuals, but our system is not as responsive. And so therefore there's kind of the cyclical effect of assaults and, all of the negative things. So.
And, just to close the continuum, acuity doesn't stop at discharge from a facility. So we're
trying to place people that have more complex behaviors in the community and community struggle. So it's all the way through.
Well, Sue, you want to talk a little bit about flow chart depicting individual course through criminal justice, civil commitment system?
Yeah, so it just says Minnesota Rule 20 process, just so that people have it in front of us, and it was from the Competency Restoration Task Force. So you can see number 1 is arrest and booking, and then the criminal court process begins. Someone goes to an arraignment, they have the hearing, but then there might be, let's just keep going down to the competency. So it goes down to someone makes a competency motion. They don't believe that the person may be able to participate in their defense. So they do an examination, determination if they're competent, then they go the other way. If they're not competent, then they begin a civil commitment process. They go through pre-petition screening, they do another examination and determination. They can then be committed, and then they could be provisionally discharged, or they could be kept in the county jail, as you can see there. And then also, if they're not committed, which happens for more than half of the situations, those are called the gap cases, where then people aren't really connected or referred to services at all. And so that's kind of the process there. So it's not really complicated. It's just that not being competent is not the same as meeting commitment standard. And that's where we run into all these problems. And then people are waiting, particularly if they are committed and waiting in the jail, and then they're waiting for services. And the new process, of course, is much more complicated. They're actually working on it now, which if we can even get the new process going, I will just put out a little thing there that, money was appropriated. Neither the counties or the courts wanted to be responsible for the competency restoration kind of implementation and group. And right now the money is sitting in MNV and they have no way to officially get started. And it's a huge problem because we need to move this new law along. So I just found that out on Friday. So there's a problem there that would be really helpful, perhaps if the governor stepped in and figured out who can actually help get this group going. So we have the small group.
The Competency Attainment Board.
Yeah. But getting it moving has been really difficult.
It's been difficult. I'm not the chair, so I don't want to speak for the chair, but it's been difficult to get started in various ways, including accessing funds, getting an email website, things like that.
And I think the importance of it in this whole discussion is that, especially for those gap cases, those are the people that you often see over and over and over again. And so is there a way that we can get people connected to services and connections in the community so that you don't see them again in a couple of months instead of just being released into the community? Right. So it would be nice if we keep that there.
So may I point out, Dr. Hart sent over, I think today, this flow chart, which shows the new process as intended. This, I think, would be a really lovely Robert, whoever put this together.
NAMI.
Oh, did Elliot do this?
Yes, your
Okay,
staff.
well, yes, so I think this is really helpful to see how it should work, within the next year or so. If folks want to take a look at that.
Yeah.
Is that the one without a title?
It has the purple box on the left.
Website.
Yeah, so the big change there again is that you don't have to wait for a commitment, or it can just order the person to whatever level of treatment that they need. And hopefully we'll be able to have lockers, or we can call them something else, flexible locks, but they won't be built if we can't use Medicaid.
So let me just ask you this, Sue, just so we're all clear, I'm clear and everybody's clear. The bottleneck where you have people who have been found not competent and yet are waiting some form of service. The problem we're trying to solve here, where is that? Just put a circle around it.
They're at the bottom. So there are people who have been found incompetent and committed and are in the jail.
So would they be number 5? On the blue map?
That's the phone.
I was thinking they were 4.2.
You can kind of see it on the second page. too.
Okay.
That
Would
might
they be in, would they be in 4.2?
No, they're in,
I think that we.
The
gap
Okay,
cases. No, gap cases is when you're deemed incompetent, but you're not committed.
You go home.
Right. So they're the folks,
Services.
so they've been committed. That's, so number 5 is they've been committed.
Okay, so they've been committed.
And then they could be originally discharged or they're sitting in the county jail. And they're
Okay.
waiting then to go.
So they're at 6 or in this unnumbered community or jail.
Yeah.
Like right there. Right?
You have another map too. There's like a million of
There's a
these
lot of
maps
them.
floating around. I think the big part is just that, you have a whole bunch of people who are not committed, but they're deemed incompetent to stand trial. And that's a whole nother issue because if they're not getting connected to things, the time that they come back, they're probably even more sick. And so we're just kind of making it much worse. And then the folks who are committed are waiting in jail then, to go to.
If I may, there's, as you can see, there's lots of,
There's lots of road charts.
but it's in an effort to try and simplify something that is extremely complicated to work through. I would say this document here is the civil commitment process. This is specific to when Rule 20s are involved. And I would insert this as starting at 3 and ending at 5.
Yeah,
On
makes
this
sense.
map. So it's kind of the insertion. So it starts at 3 and ends at 5, and it talks about all of the left turn, right turn, and standstill moments that happen along the way. So I really appreciate this because this is digestible. This is very much not, but to get to the specifics, this starts at 3 and ends at 5.
So we can jump back to the last meeting. The people who are sitting in Anoka County Jail and the people who are sitting in the Hennepin County Emergency Room, they are,
The emergency room isn't on here.
okay,
If they're in the emergency room, they have.
Potentially could be the committed and waiting.
It could be.
We have some committed patients who are sitting in, yes.
But usually they're committed once they're in the bed. I mean, a lot of people coming to the ER are not yet committed because they're being placed on a 72-hour hold.
We have
See a lot of
yeah.
people who are
Yeah,
committed.
unfortunately,
We see a lot of people that are committed.
so doctor, the guy who we've heard about this, it might not be the same guy, but we've heard about a person who's assaulted like 100 people or something. What boxes is that person? What box is he in?
Committed and inpatient.
Okay.
He's in a bed, not a state bed.
And from what I've been told by Dr. Cologne on that case, St. Peter will not accept him.
Because he's too assaulted?
I don't know the exact reason why, but St. Peter, they're waiting for this person. They've been waiting for this person to go to St. Peter. It hasn't happened. He keeps assaulting our staff. And I don't know why he hasn't gone to St. Peter.
And we do have to be careful about his private health information, this public meeting.
Just for the record, no one has ever said his name, and please do
No
not.
identifiers.
Right, and please do not. But just like speaking just theoretically, I just was curious about where that case is.
He's committed in Jarvis and considered MIND, as we understand, mentally ill and dangerous.
But because, hypothetically speaking, someone is in a hospital under that scenario, they do not qualify for priority admission. We have to prioritize people sitting in the jails,
Got it.
even though, everyone qualifies, everyone could use that same med. But we're not allowed to have discretion to admit this individual instead of, and sorry to pick on you, but sheriff representative, from the jails.
Does that explain this chart too? Why the blue lines are so high?
Yes.
Okay.
And I want to go back to Angela's point. So I think this is what we think life should look like, and this is what we get. And like Sue was saying, oh, okay, so that patient you're describing is not in the emergency room, they're in the inpatient. Well, no, they're in the emergency room because like Angela said, you don't have the right bed available at the right time. So now you just have people all out of sorts. So we do end up with people who are committed, people who are newly committed. We start commitment processes in the emergency room now. So then you might get somebody who has a revocation order, and they're also in the emergency room waiting for that inpatient bed. So all the people that used to belong somewhere else on the map are out of sorts. They're not where they're supposed to belong at all.
Everyone's out of sorts. And you gotta remember, we were doing a simple chart for the legislature.
And all that being out of sorts, it's basically that you don't have the capacity when you need the right kind of.
I know.
Yeah, I mean, universally, one does not have the kind of capacity one needs.
And building on what Kevin said, if we were gonna build in some capacity, if this group theoretically, hypothetically were to say, we need more capacity, where would we be advising the legislature that it needs to go?
3 to 5, like all of it.
It's all of it, honestly. It's not just one, because if you only add beds to, say, Anoka or St. Peter, you still have all these other bottlenecks in the system. You know, I mean, right now, I had a call yesterday. The person needed a therapist and a psychiatrist. Somehow they were able to get a psychiatrist right away, which was like totally unusual. But the therapy visit is 6 months out. Well, if you can't even get like the cheapest service we have available when you need it immediately, you know what's going to happen in 6 months. They're going to be a whole lot sicker, right? And so it is really, when you look at like all the reports, people don't just say one thing; they do a number of things.
Yeah, true.
Because you almost have to.
No, and I hear you, Sue. I really do, and you know so much about this. I'm so grateful for your presence here. But in terms of trying to go drive this process to some form of a legislative solution, are there certain parts of it that might need attention sooner? I mean, where can we add value, you know, to try to undo some of the bottlenecks? Is that something?
But honestly, I was thinking the same thing. You know, I mean, anytime you say the problem is all of it, which I totally understand and agree, well, then if you're going to approach solutions, you have to segment and try to figure out, okay, what can we do, you know, kind of one step at a time, knowing that, you know, part B, you know, is going to be as important as part X, you know, when are you going to deal with it? So I don't know if there's a framework where you could say, well, what is the short-term solution to a crisis that we have, which is essentially the way I look at it is the hospitals don't have the same priority that the jails have. So the idea is, well, do you reduce the number of people in jails that go to HMRT, or do you expand the capacity so the number of people in hospitals go as well as the people that are in jails, right? And so is there a short-term solution to that crisis? And knowing that at some point you're going to be able to propose your longer-term solution that does solve, you know, or solve is a big word, obviously, but take steps for solving, you know, the steps before that, the step down steps after that, you know, all these other areas that are obviously very important as well.
So I have a question for like an attorney, because I don't know, but is there a actual reason why the commitment standards and the competency standards are so far? Like, why don't they have language that
never passed in about a bazillion years? It's a very, very different standard, and you're taking away people's civil rights.
No, but I'm just wondering, like, why is that gap created?
Because you're taking away people's rights. So competency is really,
You know, you're doing a great job.
But I did want to hear her finish her question at least.
Oh,
I don't.
But I think she was anticipating after years of us having this conversation. Because to me, like, if you have one system that has one standard and says this person is not responsible for their charges because they're mentally ill. Well, if you're that severely mentally ill, you need services, you need treatment. And then we typically think hospital, but then the hospital says you are mentally ill, but you don't meet this criteria for hospitalization. So it just seems like there should be some kind of bridge, some kind of common language so those people are served.
It's two different things. So the first thing is when someone's not competent to stand trial, it's just that they can't participate in a
Right.
defense. That's it. And that's a whole bunch of the folks who then never get committed. And then, you know, if you go to the second route, that they're not guilty by reason of mental illness, that's again, that's way far down the line, and it's a much, much smaller percentage of people. So the real problem is the incompetent to stand trial or the commitment standard. And the commitment standard is really, you're a danger to yourself or others. And so you can be not competent to participate in your defense, but not be a danger to self or others. And to change the commitment law to match not competent to stand trial.
Well, I don't know if maybe match is the wrong word, but some kind of secret.
Well, you don't have to have it anymore, though. Once our new statute goes into effect, then it won't matter because the court can order them into treatment without the commitment standard. And so we'll be hooking those people up to services that they couldn't have been hooked up like right today.
But you're ordering them to treatment that probably doesn't have capacity. So like you have,
Not the hospital though.
but I feel like there's no capacity anywhere. That's the
Well,
way it feels.
CCBHC, so someone could be referred to a CCBHC for a therapist and a psychiatrist that they currently didn't have. And a lot of the CCBHCs are able to take a lot more appointments earlier, right, Jenny? Definitely than in the past.
There is more capacity around the CCBHCs. It's by nature of the design of the model. And I think, but if we're talking about some of the other community-based programs, notwithstanding CCBHC, we do run into some of the same capacity concerns and conversations. So I think if we, to the point of, and I don't know where this falls in the list of priorities, but if there can be parallel actions that are being taken, I think absolutely we on the community-based side, we know that there needs to be investments in beds and capacity in the hospitals. And I think there's a lot of work that can be done on the community side around adding some more flexibility so that we can respond to some of the demand and some of the backlogs. And so I think there are some things that we're exploring that may feel very unrelated, but we think if we're talking about the continuum, they really are. We're seeing very strange prior authorizations and arbitrary thresholds where we have limits to how many appointments we can provide to a client in a year. We're seeing very bizarre, some regulations that I think were put in place for really good intent, but we've got so much administrative burden and such a backlog of being able to get our programs certified and licensed by the state, that's also creating a capacity issue on the community side as well. So I think if we can provide some of these parallel solutions around being able to offer some flexibility for our community-based programs and opening up some of those doors, if you will, I think that can also help with some of the backlog on the inpatient side.
I think it's a good point because what I was talking about is a decision-making approach, not a solution approach. Because in the end, what we propose is it has all the parallel issues as well. The question is, how do we attack thinking about these things in some sort of systematic way?
So does that lead us into the summary of all the reports that have been done?
Yeah. You're up, Sue.
Well, so I went through a bunch of the old reports and I want to say that there are just.
Is there a map?
No.
Thank God.
But there are some things that really have appeared in numerous reports over the last decade or so. A big thing has been county mobile crisis teams.
I'm sorry, Sue, are you referring to any document here or?
It's a recommendation from previous reports.
Yeah.
So a big thing is the crisis teams, because we do know that they can be very effective. But what we spend on a crisis team statewide is much less than the city of St. Paul Police Department. And so it actually used to be Rochester, but I think because of the last session, it came up a little bit more. So we can't expect the crisis team to respond the same way that police do, but they still are able to resolve a lot of things over the phone, and then they can go out at times. And the crisis beds have also worked really well too, so that they're not necessarily stuck in an emergency room. They don't need hospitalization. I mean, most people generally for any healthcare issue that go to the ER don't need to be hospitalized. And so the crisis beds really become a great way to get someone stabilized, but we need more of them. And then some more psychiatric emergency rooms, because that becomes a quieter place for people in an emergency room. And then there's continuum, all the continuum, so hospital beds, residential crisis beds, intensive residential treatment. I did find one report, I kept digging, and this was back in 2017. It was from Wilder Research, and they worked with several of the hospitals to try to identify like delays in discharge. And based on their estimates, they said, and this was in 2017, that we needed 72 additional IRTS beds, an additional 70 beds at AMRTC, 54 CD beds, 46 more CVHHs, and 24 group home beds on any given day to serve those 20 pilot hospitals that were involved. So, we didn't have to go to the math department. I found it here. They at least put that together, but that was 2017. We do know that telehealth and telephonic care has helped tremendously. And I think especially in some of the emergency rooms, using that when you don't have a lot of psych staff can really help you address someone's crisis. And also the telephonic care for people who have been, who don't have smartphones. IRTS, we would want to have Minnesota Care cover their room and board because that has actually been a barrier for people getting into IRTS. And so that would be helpful. We have found some weird things with county borders and ACT teams. So knowing that it's, funded by Medicaid, it's particularly true in the metro area. So I had someone who was living in Ramsey County with their ACT team, but they found some better, frankly, safer housing just across in Dakota County. But that meant that they were going to have to lose their entire ACT team, which destabilizes the individual. And so I think there's some things like that when we want to really keep people stabilized. Improving the discharge from hospital or jails. I can say, and I know that hospitals run into a problem, but a lot of the calls I get from family members are that someone actually has been committed, but they're being discharged to the street, and we've got to figure out a better place for them because we know what's going to happen there. And then nursing homes also really don't take people with serious mental illness who also have healthcare issues, which puts a problem on like IRTS facilities. We don't have the nursing staff to take them, things like that. I'm actually meeting with them later this week. And that's because we used to dump people with mental illnesses into nursing homes. And so now we have these screening documents to keep them out. But sometimes that's actually what they need because of their nursing issues. And then, we have protected rates are a huge issue. So hospitals, most of them had bank beds. They could have added inpatient psych beds at any time without going through the process. But they don't because the payment rates are low, and so they don't want to add the beds. Even our critical access hospitals, like in rural Minnesota, they have a limit on the number of beds, but there's actually a federal law that exempts them if they add psych beds, but none of them have done that. And that would help in rural Minnesota especially. So can we figure out, some rate system to make sure that they can add beds, because that would help with capacity, particularly in rural Minnesota. But then just rates generally are a problem. We have protected transport in our state, which would really help, frankly, sheriffs not have to transport people, but the rates are so low that hardly anybody does it. And again, people could be transported with dignity, and that would really help. There's a need for all type of housing. And I just want to say that what I hear anyway is that a lot of people with more serious mental illnesses, particularly schizophrenia, don't want to live in a corporate foster care setting with 4 beds. People are sensitive to noise and smells and everything, and then they're in a house with 3 people they don't know or like, sharing a bathroom and a kitchen and living space, and that's really hard for them. The places that they have seem to have done well are places like Rising Cedars, run by Touchstone, but the department isn't allowing those kind anymore because they said that they're institutional because everyone in there is on a caddy waiver. But yet when you put that many, maybe it shouldn't be 30, maybe it should be 20. But then you actually have enough money per person to actually hire mental health
So how's the
professionals.
facility, I'm sorry, how's that facility set up?
Would they use a caddy waiver?
So, but no, is you said a 30%?
Everyone
in a
has their
single
own
room,
apartment.
right?
It's actually really pretty. I'd live there. And so it's really pretty little apartments. People can have a joint meal if they want to. There's meditation rooms. But because you have 30 people, you have enough money per person to actually hire mental health professionals and nursing staff. And we've seen people there who've been in and out of Anoka and everywhere else actually be stabilized there. And so,
How's it licensed?
well, it's because it's the number of caddy waivers.
So how is it currently, what's it called? The license, is it?
It's not, they have their own apartments.
It's housing.
It's housing. And then you're using a caddy waiver to provide the services.
Okay.
And then we need, we have workforce shortages, huge ones. There were some good things past this last session and the session before to keep addressing it, but you know, you can ask any of the hospitals, any of the IRFs facilities, anyone, they're like, we can't find people. And then greater collaboration on the local level that came through. And then a big thing, which kind of goes to the point that you've made, is that we do, frankly, a pretty crummy job with people who have a mental illness and a substance use disorder. Either it's too short if it's in the substance use disorder facility, or not long enough if it's in an IRFs, and you can't necessarily address some of these huge addictions in 30 days or even in 90 days. And so we haven't done a good job. So, I mean, you can look at all the rest of it, but those were kind of the common themes that kind of keep coming up and up and up.
So I kind of expected liability issues to be in this common, this the themes. Does that not rise to this level?
Not in the.
Okay, okay.
No. So just wanted to, you know, say there, I mean, there has been a lot of work over the years to try to identify solutions to these problems. Just reminding you, we've never had a mental health system. And so, you know, we've been trying to build it, and the things that work, people want more of, right? People want more IRFs, you know, crisis beds, things like that, because we know that they actually work.
Questions? Suggestions? Comments?
Comment of speaking to the liability piece, the part that I have heard about the liability that comes into play is when we're working with populations that have a lot of behavioral needs. There's, you know, histories of assaults or things like that, where the community has a hard time stepping in and providing that level of care because, I mean, frankly, it's their livelihood, it's their business that they're putting on the line. And there's a lot of so our private provider base really feels that the liability is too great to serve some of the individuals that we're talking about on this map. You know, not all individuals that we're serving within our system, and in many ways we're doing fairly well with some of the greater population. I really appreciate this because it outlines very real. It's very real about what we need, but the liability is that those that have high behaviors or history of assault, history of aggression, that is where providers are stepping backwards. And that is where my understanding was the primary reason that providers did not respond to the department's RFP for secure IRFs, because there's a number of reasons, it's my understanding, but one key one was the amount of liability that's placed on private providers. You have one incident and all of a sudden licensing is, you know, at the forefront.
I've got a question, Sue. You mentioned the 4% group homes. We have a lot more options now with 1-person group homes, 2-person group homes, for kinds of waivers. Do you have any? I have more hope for those. What do you think?
Well, but then you're isolating someone who also doesn't know necessarily how to reach out. And so we've seen people in their just regular apartments actually not do well because they're not really connected to other people. So the isolation thing is huge, I think, for someone with schizophrenia. And so, you know, being able to be in a building with our other people who've had shared experiences, and again, we could make them smaller, but you're not able to find, and I don't want to put down people who are working in a 4-bed group home, but they often don't have, frankly, a lot of training on dealing with serious mental illnesses. And so then they end up in your emergency room because they don't know what to do, or they get scared because someone has bipolar disorder, and then they call 911 and then the police come out. And so I'm gonna be honest, I don't think it's necessarily a good idea for adults with mental illnesses who don't have those like super violent behaviors. They just need to be with other people.
Yeah, and if I could just add to that, first, Sue, thank you so much for putting this together. I think all of this is reflected in the calls that we get, you know, every day, every month, every year at the Office of Ombudsman for Mental Health and Developmental Disabilities. But to the 4-person group model, and to Commissioner Harpstead's question, I also think that yes, while we do have homes that are serving maybe one person, maybe two people. Typically, by the time a person has gotten to where that might be an option, any number of other things have failed for them. And so there's a reluctance on the part of private providers to want to sort of jump in, having reviewed what might be on paper in a person's record in terms of all of the things that have failed and issues that have happened in the past, frankly, perhaps due to placement in a model that didn't well fit their needs. But nonetheless, there's kind of this additional stigma. And so then at that point, a lot of times we're looking at trying to advocate for direct hearing treatment to step in and try to develop perhaps a model for them. And while we appreciate our partners at DCT and willingness to do that, the reality is the time that it takes to stand something like that up can be quite significant. And so it can be, 9 months, 12 months beyond. Before something like that is available. And so I think one of the things that many of us have been talking about throughout these meetings really is about how do we create a system where there's a capacity for people to access the right level of care at the right time. Sure. And could I just offer to that, Lisa, and I think a little bit to respond to the concerns about liability. I think some of it is, yes, absolutely liability, but I think I'm only going to speak for my MAC members. I think some of it too is making sure that we have the appropriate model of care for folks when they need it. Yeah. And right now, if we're talking about IRTS at least, IRTS as a model was not designed to take on some of these much more acute folks who might be a danger or to themselves or others. And I'm not trying to just mire the problem or say we need to build something else. But I think if we have expectations for some of these community-based models that are not currently what they were built to do, and it is about capacity and time and resources to be able to get us up to that point. And so it comes out as liability concerns, and those are really real. And it's also, saying, are we trying to, in some ways, put a square peg into a round hole with some of these immediate, some of these immediate things that we're trying to solve.
We've been wondering for some time if we had a group of providers that we could talk to who would be willing to step up to create a community of practice of taking more acute patients with additional training, additional funding. Are there folks that would stand up to say, this is part of our mission, we'll give it a shot and work on the higher acuity models for a while with each other and see what they can learn and develop?
Terrence Unlimited had, I think it was 4, 5, maybe it was a 6-bed where they were taking people who were deemed incompetent. But then they lost their funding from Hennepin County, some additional funding to be able to do that. And their thought was, if you were going to do that, you needed to be smaller, not 16 beds, it needed to be smaller. So you have to, make sure the rate was enough, but also that it couldn't be done in 90 days, that it had to be done in closer to 120 or so days. And so that change would need to be made too. But they closed it down, but because of lack of funding.
Why did you have some things in yellow and others not?
Good question, right?
It says being implemented or slightly implemented.
Oh, yeah, something's passed.
Okay, highlighted in yellow. Got it. Several of the recommendations and implemented.
Yeah, those were things that passed.
So the yellow stuff is either happening or happened.
Yeah, mainly passed. Whether it's been actually implemented is a whole other thing.
In the last legislative session or?
And some before that.
Oh, yeah.
Like the bed tracking system has been around for 5 years.
And it all starts with a lot more money, that's what I'm hearing.
It will, but it's not like you can solve these issues without it.
That's why we're curious about a community conversation about providers that might be willing to step up to take on some of the cases if they had the money and they had the flexibility. Because even if you had the money, when they say they don't want to touch it, can we get some folks who will say, yeah, we'll step in.
So Adam Smith may have some limits here. The amount of money, you can't throw enough money at something.
We struggle with that, trying to get medical in the jail and providers saying we don't want the liability.
Yeah.
No matter what the amount is.
But in the situation when you have the one or two, and I don't know very much about it, I'm curious, I've heard in situations where it sounds like maybe the person you're talking about, or the hypothetical, situation where someone's been, just repeatedly assaulted and there's just no place for them, that what DHS or others have done is they've actually built the facility to suit the person. Right? And I don't know if that has been successful or not, but it seems like in some of those situations, there may be no other choice.
Private providers have too.
Maybe my experience is skewed because of where I work, but I just have never seen a successful group home with a single person. As Sue said, they're isolated, so maybe there are obviously staff that come and go, but there's not like a social relationship because they have to have boundaries. You know, it to me, it's a last resort, but it doesn't seem to be the right response. I don't know if anybody's ever studied them, but I have never seen it work and it's super expensive.
We've been wondering if it's a transitional service. We've got some of these folks that are stuck now and very dysregulated because they've been stuck for a long time. Is there a place for someone to heal and then examine, now what's your best place to live as a transition and not a permanent situation? And there are some providers willing to step up. That's why I'm suggesting that model.
I know we have, in our county, 32 group homes. And a lot of them, like she said, don't have the training.
Yeah, these would be specially trained and higher paid.
And then, when something does happen, they call 911, we come, and then they end up in the jail, the circle starts again.
Yeah, I understand.
And then, now that they've been placed there, they've been seen and they've been diagnosed, it has to start over again through ER and through this and through that. They don't just get to go back into a setting.
Could somebody just talk a little bit about what IRTS is like? I mean, I know what the letters stand for, and I can surmise kind of probably what it is, but I don't really know anything about it. Would anybody mind just taking 3 or 4 minutes to just say, here's IRTS?
They're residential facilities,
Okay.
up to 16 beds or rooms, and that's federal
Got it.
law, so they are not deemed institutions.
Okay, so IRTS is a federal statute.
No, it's a state statute, but we still have to fall within the parameters to not be an IMD.
Gotcha.
So they're residential facilities or folks. Sorry.
I have no idea what an IMD is.
Institutes of Mental Disease.
Gotcha.
And that part is federal.
Okay.
But so they're
Which means you can't use Medicaid.
Correct.
You can't use Medicaid if it's over 16 beds for over half or more of the people are being treated for mental illness or substance use disorder, which is why there's 16 beds.
Yes, and the piece there is you can use Medicaid, but the feds won't provide the federal match for it if it's beyond that limit. So that's why they're limited to 16 beds. In Minnesota, there are 90-day, sometimes less, but between 30 and 90 days stay. And they live there, receive meals, and then also receive intensive mental health services while they're there. And so they can vary in size up to 16 beds, so some are smaller. And then the services are intended to be much more, they're not acute, so they're not inpatient, but they get a lot more touch points and a lot more kind of intensive ongoing service with the staff who stay in the facilities or with them in the facilities as well.
Okay.
The staff work shifts, but they're 24-hour shifts because folks are living there at the same time. And then, I know that we had a couple of members of MACMAP where they had different population focuses. So a lot of them are for adults. Some are with pregnant mothers or mothers who've just had young children and are needing transitional plus housing supports. Most of them are for single adults who need the housing and the intensive nature of the services to put together.
Does it include mental health and physical? Is IRTS a mental health thing?
Primarily mental health, but
Okay.
they usually will have relationships with primary care and will be able to do referrals up to primary care or have different arrangements at the local.
And is it facility based in that there's no scattered site IRTS? It's just you live here. Follow me? So if you're an IRTS person, you live in the IRTS building. You don't live
For
90 days. You're not like off on your own and the IRTS person comes to you.
No,
Right.
no.
Okay.
That would be a sort of community treatment or adult rehab mental services.
Thanks a lot.
But that goes to my point, because I have never understood why when we deinstitutionalize the system, that we didn't account for the people who are on the like extremes of the bell curve. So like people who need the IRFs indefinitely. And not a group home, but a state-run facility where they have all the programs there, like the old state hospitals, but in a more like progressive and open way. I just don't understand why we haven't really accounted for those people. So like you were saying, the person fails that group home, and then they start all over. What is the trauma that happens to a person when they repeatedly have to start all over? To me, we are doing a greater harm to that person who has to repeatedly build a new system when there could be a long-term IRFs type program where you could have a safe place to live, where staff would get to know you over time, where you'd have all your services and not have to leave in 90 days. Like the system now does not have a good place for those people.
It really is the Touchstone program, and there's other, there's other providers who do that. I mean, it's really.
But you're counting on a private program to do that. I think there should be, within the state system, there should be that.
But why should the state run it if a private provider is doing a good job?
Well, I'm not saying it has to be exclusively like only, but I think there should be like a public option. Oh, I said the public option.
I mean, it's not private pay.
Yeah, it is a public program. It's just being operated by a private C3.
Yeah, but you're suggesting the state of Minnesota invest and run some of the program in addition to private people, both state-run and private run.
In addition to the Touchstone model, which is just a great model for some folks, we also have assisted living providers who are specializing or purport to specialize in serving people with serious and persistent mental illness. I think there's sometimes some issues with that, and we actually have the level of training, but if we were to imagine what might be an option or something that we could expand upon with some additional training requirements, really making sure that the staff have some specializations, that might be a model to look to for inspiration, and then kind of collectively identify where there are tweaks that might be needed to look at the population of folks that we're talking about.
Is that the same as adult foster care?
No.
So who are those?
Oh, I'm thinking of a provider in southeastern Minnesota who for years, even prior to the implementation of assisted living licensure, really actively sought individuals with severe and persistent mental illness as part of their client population. They had psychiatry that they would bring in on site, a variety of different partnerships with community mental health programs and professionals and armed services. And I think at one point there was an ACT team involved. So I mean, there's been some exploration of this kind of things in different parts of this state. I think practically speaking, it really, in a lot of ways, mirrors what Sue was talking about in terms of that Touchstone model. It's just a little bit different in terms of how they implemented it. And could that be something to look to, again, not as a sole model, but as a source of inspiration for what we might look to put together? Because I've heard from a number here today, and I just want to absolutely add my voice that I think that whatever we do really has to be a multimodal type of solution, so that we really are allowing for some real person-centered approaches to kind of meet people where they're at, and ensuring that for folks even who might have the most significant needs, that we're offering opportunities in the process for some kind of informed choice in the individual. Because from our office, we've seen where people feel like they don't have a lot of agency or they didn't have any opportunity for choice. A lot of those programs are just not as successful as they could be without the buy-in of the individual as part of the planning process.
So hey, everybody. Oh, sorry.
I was just gonna add, I've been in a lot of intense conversations in the last year about how we're gonna get this person out of here. And it's wonderful when we can change the subject to how do we give this person their best life.
So we're about at our break time. We went a little over. That's a good thing. Conversation was flowing, so I didn't stop it. But we were supposed to break at 2:15. You guys need to, take a few minutes to do what you got to do. So let's just be back at 2:40. Does that make sense? All right, 2:40. All right.